Productive Dentist Academy podcast network.
Hope is still there. You can take control of it. You just need to take the right steps.
Welcome to Investment Grade Practices Podcast, where we believe private practice dentists deserve to get the lifestyle today while building an asset for tomorrow. Join your host, Victoria Peterson, to design the practice of your dreams and secure your financial independence. Let's get started.
At what point does a successful $2 million practice quietly become stuck? When your schedule is full, when your team is working hard, and yet your profit margins keep getting tighter and shrinking. This is not random, this is architecture. Hi, I'm Victoria Peterson. If you felt the squeeze of rising payroll, increased supply cost, and shrinking PPO reimbursements, well, you're not alone. And I'm sure you're wondering why working harder isn't creating more freedom. In this episode, we'll give you clarity and a framework for what actually moves the needle. Today, I am joined by the one and only Kari Miller. She is a senior business advisor in our investment grade practice consulting team. Kari, welcome. I'm so glad to have you here today.
Oh, I'm so happy to be here. Thank you for having me.
There's so many ways we could take this conversation. You've been I knew you before you were a coach with PDA when you were an office manager in a real high level aesthetic practice in downtown Seattle. How long have you been with PDA?
I'm working on my 16th year, so 15. This will be my 16th.
Wow. Wow. We were babies when we
I
started.
know. Oh, I don't know what you mean. I still am.
That's right. Well, you have a wealth of knowledge. You have worked with hundreds of practices these last dozen or so years, and I'm going to be picking your brain in particular about that place where doctors get the practice is above 1.5 million, like easily. They probably have brought on an associate or are thinking about bringing on an associate. Their service mix is really good. You know, they're doing more than bread and butter dentistry, but they're kind of plateaued. So that's a conversation I want to get into with you today.
Yeah.
So let's start with data. Let's nerd out. When you see a practice like this and you're evaluating it, what do you consistently see? What does the data show you?
Well, really, when we start looking at it, PP write-off or PPO write-offs are really between 35 and 55%. Revenue has flatlined, so they're becoming really productive, but they're not taking home more. Hygiene labor costs, they're not able to keep up with, the diagnostic, kind of 3-to-1 ratio because of the insurance reimbursements. So there's higher labor costs that are associated with it. And they're really expanding their service mix. They have a really great service mix in place. However, insurance is still dictating what they can charge for each of those. So it's still restricted on what they're able to do for those. So although they're expanding their service mix, they're still getting, you know, minimal reimbursement from the insurance carriers.
Okay, so and I see that path too. We use in-network plans. I mean, everybody's on Delta. Not everybody, 5% are not. And yay for the 5%. But, we're on multiple plans, and that's a great growth strategy, right? If you've got no patients or you took over a practice or the early days of your practice, you want to get volume. You've got to get above 1,200 patients of record. You're moving to 2,000 patients of record by the time you're at this level, maybe 3,000. But at some point, that busyness volume game stops working because it doesn't translate into profits. That's what I'm hearing you say.
Exactly. And, they've built that stage one of growth through the volume. And now they really need to hone in on the precision of stage two. And that really takes kind of the nuance and really looking at it, clinically and kind of through an eyeglass.
I'm so glad you're here with me today. On the last few podcasts, I've been telling doctors, and I'm going to keep telling you, you're not broken. You don't need a personal self-help class. This isn't really about you. What's generally happened is that the business is built around you and not for you. So, Carrie, what I'm hearing you say is if we can fix the structure of this a little bit, doctors will start to feel the freedom like the business that works for them. They don't have to work 5 days a week. You don't have to put out every fire. You're not the HR culture ambassador plus the financier plus the clinician.
At Productive Dentist Academy, we've helped thousands of private practice owners find the clarity inside their data and take control again, starting with a free 60-minute coaching session. Head over to investmentgradepractice.com right now before the next patient sits down to claim your free 60-minute coaching session. That's investmentgradepractice.com.
Exactly. It couldn't be more true with what you said. It really is like they start to take ownership where if the practice isn't running them, they start to run the practice and start to see where there's opportunities.
Okay, so I want to move into something that's counterintuitive, and it may not seem apparent at first when we're talking about data and profit and numbers. But from what you and I have seen, and Dr. Baird, we co-founded this company on this premise that telling patients everything that you know, doing comprehensive diagnosis, and doing it in a way that they don't go screaming out the back door, right? That's the key is the communication skill, but diagnosing by risk factor is really one ethically sound. It's in the ADA Code of Ethics. It's called veracity, you know, being honest and telling them everything. So before we can even get to should we renegotiate our PPO schedules, we need to take a deeper look. And you said something really interesting that by the time you're in, 1.5, 2 million, 2.5 million, you've got a strong clinical mix. But what I've seen is does everybody on the team know what that is, right? So what is our philosophy of care? How do we know, when I see a hole in the tooth, how do I fix it? How am I going to prevent it? What are the risk factors that got the patient here? So I think you and I would say a common theme is that almost everybody we work with say, we want to do great patient care. We want to do what's best for the patients. We want to do what we would do in our own mouth. I hate treating one tooth at a time. I hate treating just the emergencies. But um, what do you think holds them back from having that like modern health paradigm diagnostic standard? What do you see as holding them back in this pinch point?
Well, I feel a lot of it is where they're not calibrated on, and there's inconsistency with how every team member is talking about things in the same way. So I want to make sure that that's something that we're very intentional in when we look at it clinically. We want to make sure our hygienists, diagnosing differently than the doctors. Are we really evaluating risk factors? We see inconsistency throughout each one of the different, you know, um, departments. And so really getting solidified on how do we want to care for patients? Because this is the mindset from what insurance covers versus what we actually believe in the care for our patients. And so we need to just, that's the team heavy lifting is getting very, conscientious about what do we want to do because dentistry's evolved over time, with oral systemic, airway, the preventative, so many of these things, we need to make sure that we're calibrated as a team so our value stays there, that we can really stand behind what we would be charging our patients if we weren't restricted by what insurance covers.
That's showing up in some of the trend data that I'm seeing right now, like the average boy, it sounds like I can't talk or that I was never a hygienist. The average periodontal code utilization across the country is about 7%. And when you ask clinicians, they'll say, "No, for adult patients, it's 30, 25, 30, 40%." So there's this differentiator, and you hit on it earlier, like there's a scheduling kind of block. So what happens if you do have the capabilities? I mean, this must be so frustrating for doctors. Yes, I can place implants, I can do full mouth rehab, I could do quadrant dentistry, I can do aesthetics, we can do, um, preventative. We can have modern biofilm therapy for our patients, but they're not saying yes. That's one problem. But the bigger problem is they say yes, and now we've got to bill it through insurance. What happens there?
Oh, well, if the documentation, I mean, you really have to fight for the patient, of what you're wanting to do, and it becomes a very heavy lift for your administrative team for going through that and making sure, well, do we have the right documentation? Is this all under what insurance's guidelines are? Even though you're the doctor and you're creating what parameters and protocols you believe your patient should go into, insurance is dictating something much different. And so you really have to fight, which takes up time where we could be doing, face-to-face patient care versus, working with the insurance as far as trying to get them reimbursed for what's truly going on in their mouth.
Give me an example of what that looks like in real life. Let's say I just extracted some teeth, put in a denture. I have my fee for service fees. I throw them in there. It goes to insurance. What happens to that?
Oh, well, I mean, if we're talking about this, let's just say you want to bill out an interim denture so they have something that's going on, or have teeth at least, after their appointment. Well, insurance usually only covers one denture. So it's either the interim or the final. And so you're now placed in this position of, well, which one do I bill out for? Because truly the best patient care is for both of them. And then we have to, have a conversation around the patient of your insurance will not cover the second one and they won't allow you to charge the patient the second additional one, which is really the biggest challenge when you're in network with a lot of insurances. So it just takes the frustration and you're not really able to provide the best care. It starts to dictate the type of care you're able to give.
That doesn't even sound like a write-off. That sounds like I'm paying the patient to come in.
Absolutely. I worked with one doctor, and when we did started to do a deep dive analysis, um, he was working with a denture patient. Lab cost, of what it was, around $600 for the denture, he was getting reimbursed $550 for the actual denture, and that is, like, he's paying the patient, not to mention the chair time, not to mention the overhead for all of those things that add up, and the numerous appointments that, come with delivering a denture and making sure that it fits right through the healing process. He's like, "I just can't even provide this service that my patients want, but I can't afford to do it. I'm paying them for it."
It's costing him $1,000 and he collects 550.
Yeah.
And it's so hidden. It's not obvious, and it's not even if you have a really high-level office manager, having the time and the expertise to put all these numbers down and analyze it can be somewhat time-consuming. I know you're a whiz at it, but, it just seems crazy, and, we're saying dentures now, but the same formula flows for all on fours, your prosthetics, everything, the numbers just get bigger. So that's so step 1, you've given us 2 clues here about why we may have plateaued. Number 1, our race to revenue and our volume strategy may have peaked. Like we filled all the chairs, we filled all the time, we're peaked, but now our write-offs are getting bigger and bigger. They're all bundled in a network of an umbrella, so it's hard to see. Maybe we get that analyzed every 2 years, every 4 years, if you're really on top of it. So it's easy to see from the data that it shrinks, but then there's these hidden softer things of, um, even if we are comprehensively diagnosing and treating, the reimbursements are so low that it actually costs us you can't afford to do that sometimes in this environment. Um, I was chatting with a practice, recently, and they have 4 doctors and 6 hygienists, and we were talking about diagnosis, and I said, "Well, what talk to me about the exam and what triggers the diagnosis." And they said, "Well, usually the patient has a complaint, something that they're, concerned about. We take a look at it, and they ask if insurance will cover it, and I say yes, and that's where we start." And I said, do you ever notice that there are other things going on in the mouth?" "Oh, yeah." "And do we talk about that?" "Not usually." So I think what's happened is we've unintentionally, and this could be part of the burnout, it could be part of the it's part of that constriction, like, why I just want to be unrestricted. Let me do what I do as a clinician, right? So that tension there between I know what is right, but I know I won't be in business if I deliver that. We become insurance educators, not patient advocates.
Victoria, you're hitting that on such an important piece, and it's so crucial when we start to really frame of when we start speaking insurance language, we're doing everything that the insurance companies are wanting. Oh, let me check to see if your insurance covers fluoride instead of bringing it back to the actual risk factor as to why we want to do fluoride, whether insurance reimburses it or not. And that is where we need to really be hearing ourselves. How are we communicating with the insurance? What is that verbiage that we're utilizing? Because if we're educating our patients, exactly what you said, on let's see if your insurance covers this. Oh, let me pre-authorize this. It's still needed, whether it's authorized or not. And so this is that part of really just taking, your ownership of I'm going to be giving you the best care. Insurance is a, form of payment, not a form of treatment. And so you really want to make sure that you start to utilize that verbiage in the very beginning and hearing your team doing that when you start to really focus on being unrestricted.
I love it. I'm gonna take that one step further. Insurance is a form of payment. I would say insurance is a form of marketing, and right now you've got a 35% marketing budget.
I actually just talked with a doctor and we're doing a analysis right now. And when I said, imagine what you could do with $100,000 marketing budget for the services you truly want to do every month, what would that look like different? Because that is what the, the insurance is costing you at that
So
now.
writing off $100,000 a month, that's
Yes.
1.2 million of your life force energy. Whoop.
But they're producing, and it's like, "Oh, I'm trying to outproduce it," and this is where you just start to see, like, this is that wheel, you're just not able to get off until you just start to think of it in a different way, and that's what I'm encouraging everyone who's listening, start thinking about it in a different way because it doesn't have to be that way.
And we really are not. I don't see insurance as evil. It is a construct, and you have to know when it works for you and what the tipping point is for when it doesn't, and how to pull some different leaders. So let's talk about internal marketing. I know that you work with our Phoenix Dental Agency and do a lot of internal marketing. And in this situation, it sounds to me like you and Sarah would probably sit down and have a powwow. And step one would be, let's look at the patient demographics. So we have 50% that are fee for service, we have 50% that are in network. I'm going to take the part where we're going to work with someone to renegotiate and get better fees, figure out how we're going to restructure. Sarah, could you work on the piece of how we reactivate outstanding treatment for our fee for service patients? Am I getting that right?
Yes, absolutely.
How much how much unscheduled treatment do you typically see in the shelves when you analyze a practice?
Oh, I mean, let's just take a 1-year time frame, and I love doing this exercise with a lot of offices of just asking them, "Where do you think, your unscheduled treatment lies?" And what I am seeing is upwards, of 1 million up in that. Conservatively, let's just say, like at a minimum 550, to 800,000. But there's a lot sitting on that table, to do it. So it's a wonderful thing to get these patients reengaged and start to find out why weren't they able to say yes to begin with?
Now, I remember 20 years ago when you were an office manager, you were like the queen of reactivation. And like no one got out without their next appointment. And if they did, you had your call list, you had your 1 to 31 file, like you were on it, doggone it. But I think things have changed here, and from 2006 to 2026. in just the volume of workload on the administrative team. I hear doctors say, "What's your reactivation plan?" And they go, "Well, when our hygienists have downtime, they make calls." Okay, I'm gonna be blunt, that's not a plan. Hygienists will never have downtime. If they have I was a hygienist, I'm gonna give you the secrets here. If I know I've got an opening, like my next appointment, boy, this is gonna be a really difficult prophy, and that patient's gonna be a gagger, and I'm gonna note all of that, and I'm gonna take about an hour and 15 minutes on that patient instead of an hour, and then, of course, I need to clean up, and then, of course, there's some chart notes, so that hour you think that I have to make a phone call is not there.
Well, in the administrative time and, clinical time, we want that to be focused on patient care and the patient experience, not on, really kind of following up on unscheduled treatment. It is an absolute important system that we must do. And so then it's like, how can we alleviate that? Which is why I love the re engagement, is that a lot of times it's the time that we don't have. And so when we get someone to help support that actual system with, all right, they're pulling specific cases that you want, whether it's crowns, whether it's implants that you can actually follow up, whether it's hygiene to fill that. They're working that system behind the scenes so you can really focus on patient care.
Do are you seeing more and more offices at this level just outsource that to, like, a fractional marketing person or partnering with a marketing group? Because it's not just re-engagement, it's like re-engagement of restorative, it's getting the new patients back on the book, it's reappointing the right patients in hygiene, it's getting the reviews, getting the raving fans, like, that has become an entire job or a big part-time job, and I don't think we have the staffing for that inside the practice right now.
No, this is where we really look at being able to look at third party and for having those people that can help support that to allow the time for, the face-to-face care. And so when we look at that, it absolutely is helpful and it pays in spades because then it's like, all right, you don't have to be the expert in your reactivation software. You don't have to be, oh, all of the phone calls that are going out. You don't have to do. It's very easy to be like, here's the system, here's the patients we reached, here's what they scheduled for. This is our another at bat to getting them to yes, which is like, that's the brilliance of being able to have a relationship, within some of the companies that you work with.
I love that, and if you're like me, as you were talking, my brain went to, like, some old school answering service person kinda reaching out or some robotic voice going, Doctor Kari, this is Victoria from blah, blah, blah. You're due. Call us back by. It's not like that. It's like having a warm Carrie Miller on the other end that understands your team, understands your practice. So don't be afraid of that, doctors. There's a million reasons why you want to really be intentional. So if you're using 35% write off as your marketing plan right now, maybe take 2% of that and hire somebody to help you with internal marketing because that's where your next million's gonna come from. And it's
And
gonna be fee for service, and it's gonna be unrestricted.
and it's not gonna add stress to the rest of your team.
Good point, good point. Okay, so I know my data. I know why I've plateaued. I get that I need to really shore up my diagnostics so we're all looking at it the same way. I know I need to restructure my relationship with the in-network participation so I can actually bill for the comprehensive care. And I know that, we need to market towards, like, create a budget and market towards that type of patient. Now I've got another problem. So before I had challenges of scarcity, like, oh my God, I've got too many patients. I don't know where to put them. Now I'm creating challenges of abundance. Like, now I've got all of these patients and I need bigger treatment blocks. They're not like my standard 1 hour find me a crown anymore. It's like a quadrant or a half mile. And so something happened. So now my $2 million schedule that's packed because of time, and I'm booked out 3 weeks, 5 weeks, 10 weeks in advance. What do you do to evaluate that system? What do you do to evaluate the scheduling system, or how to even set goals for what we should be doing?
Yeah, there's really 3 metrics that we're looking at, which one, production per hour by provider. So you're really establishing, hey, what are we averaging so we can start to create a structured schedule around that. Production per chair gets lost often, so it's an important piece of the pie when you start to go, all right, if you have 6 operatories, where should you be at within each of those? And really your scheduling template and the integrity of it. Are we scheduling over new patient blocks? Are we scheduling over our, scaling and route planning or periodontal blocks within that? Because if there's not intentional, service mix control, your schedule starts to run you. So you need to really structure that or else it's gonna feel chaotic, even when it's full.
Yeah, I love that. Couple benchmarks here. If you're not familiar with production per chair, like an industry standard would be $25,000 per chair. So as you're saying, a 6 operatory, if I did 25,000 times 6, I'm gonna have a $1.5 million practice. I know that you coach offices all the time that are 6 operatories that are doing 2.5 million in that same space. So with that, the per chair value goes up to 41,000. And I was having this conversation with Kyle Francis a few months ago, and he's like, "That's a unicorn. That doesn't happen." And so I went back in our database and I was like, "Yeah, more than 50% of our clients have achieved that $40,000 per chair ratio, and that includes hygiene chair, right? So it's not discriminated restorative or hygiene. That doesn't mean the hygienists are producing $60,000 a month, but it means that the overall productivity of the practice, it reaches that level. So the schedule is so integral and it needs to be engineered with this with your philosophy of care in mind. Otherwise, it's just treated like a calendar. And if you treat your schedule like a calendar, you are instead of an operating system, you're never going to grow your practice. We're going to keep reappointing the same people who come in hygiene and they're healthy and have no, and all the bad patients get on our schedule and all the good ones are waiting. That's what I found.
Yeah, they need that, I always talk about architecture, they need that foundational support to be able to do that. And what we tend to focus on gets done. And so when you're really evaluating what services would fit into that, you start to realize these solo individual crowns, it's just making me busy. It's not making me really efficient and productive, and you're not, feeling that profitability. So this shows you when it's like you just are feeling exhausted at the end of the day, but you're like, I only produce this much. It's because we didn't engineer the schedule to what you really are looking for out of it.
Love it. I'm gonna declare a Carrie Miller challenge. So if you're
Oh.
listening to this podcast, it's the Carrie Miller challenge. I want you to look at the next 10 people who sit in your chair that you're doing a single tooth restorative procedure on and ask yourself, is there other disease within this quadrant or within this arch, you know, in this quadrant or half mouth? And just see, was it truly a single tooth or were there other opportunities that we didn't talk about? It's not good or bad. Our standard of care allows for all of this. It's just simply observing where we leak energy, where patient care could be elevated, and understanding what's restricting us, what's holding us back. All right, Carrie, last question. We've done a lot of data. We've done a data deep dive. I want to talk about the emotions. What do you see as the impact on doctors emotionally when they're running at this pace and profits are shrinking? What do you see?
They feel trapped, that it's hard to see the light at the end of this tunnel, they feel like they put blood, sweat, and tears into something, and they've built it to where that production dollar amount is so high, Yet when they see those adjustments, they just are like deflated. And so it really affects like, hey, how am I going to continue to do this? They get burnout much more quickly. So, that's when you start to go, all right, what does that look like? So they start to consider, I need another associate. I need to be, looking at maybe being more intentional with the PPOs or expanding my space. Yet the profits aren't there to support it, and that's where they feel stuck. They feel trapped. What they really need is to refine what they're really looking for. And I want to make sure there are very productive PPO practices. It's a different way. So this is all something that you can be evaluating and shifting to. But really, when you really are looking at what is the type of practice I want to run and to come into every day, this is where you just have to really look and structurally go through it and say, all right, what do I want? And how do we get there? And we build a roadmap together on how we can make that happen.
I love that. So you say doctors feel stuck, they feel trapped.
Ah.
When you first meet them, are those the words they're using or is it something deeper?
Oh, I mean, it's most doctors get into dentistry to support their community and to take care of people. And so when this starts to happen, they start to feel really deflated and, emotionally, they're just like, I just want to come in and take great care of my patients. Yet all these other outside forces are really trapping them into this cycle where they just don't see a way out. And that's exactly where I feel a lot of times this is that bend, that, little thing that you can just go, hope is still there. You can take control of it. You just need to take the right steps. It's, where there's a void, negativity fills it. I always say, let's make sure there's no void. We're going to walk through that step by step. So they really they're emotionally tied to it. They're feeling this, scarcity part of like, I don't know how I'm going to get out of it. Like there's no way out, this hopelessness feeling. And at my core, I'm just like, there's better ways of doing this. You don't have to be restricted in this way. You can still take amazing care of your patients and get financially compensated for the work and the investment in your CE that you do. There's a way.
Yeah, this is why your clients love you so much. It's like you re-spark their dream and then you give them the tools to actually have the team help them carry it out.
Yeah, I mean, it's a passion. It's like, gosh, we're here to take great care of our patients and clients, and I just don't want anyone to dictate what we're able to do.
I love it. Kari, thank you so much for being here with me today, having this conversation about becoming unrestricted. Know that that $2 million ceiling, it's real, but it's not permanent. And here's the takeaways that I got from you. When we standardize our clinical schedules, when we intentionally reactivate patients that align to that, when productive systems are put in place, then we can move out of this viability, race to revenue, volume stage. We can get in more of a predictable building value per patient stage, and that's not a hope or a wish. It's the reality of what you do every day. So hey, if this episode felt a little uncomfortably accurate, that is a really good thing. So if you resonated with this, just be aware that first, this is an architectural shift. And as a leader, you've likely done so many things right. You've created so much success, and you deserve to know that. And it's time to just get a better system. Kari, thank you so much for joining me here today.
Aw, thank you for having me.
At Productive Dentist Academy, we've helped thousands of private practice owners find the clarity inside their data and take control again, starting with a free 60-minute coaching session. Head over to investmentgradepractice.com right now before the next patient sits down to claim your free 60-minute coaching session. That's investmentgradepractice.com.